Hello, this is Michael Altos. We're having our second lecture on cardiovascular system, and this time focusing on antiarrhythmics and calcium channel blockers. And this is part one of the video recording. The first drug we want to talk about is digoxin. Digoxin is a drug that's had a long history. It's been around for a very long time, and digoxin is used nowadays in the management of supraventricular tachydysrhythmias. So we're talking about ATAC, A-flutter, AFib, any of these dysrhythmias that have a rapid ventricular rate. Basically, it slows conduction through the AV node and it reduces the ventricular rate, so it's good for rate control. Digoxin has some activity in the parasympathetic nervous system as well. It may decrease some of the SA node activity, which may or may not be pertinent to our patients who have AFib. And digoxin does carry some risk of developing ventricular fibrillation as well, so something to be aware of. Now, the history of digoxin is that it was known probably for over 100 years now to be a good treatment for congestive heart failure. It increases contractility, which means it's an inotropic agent, and it does this by working in the sodium-potassium ATP transport system. You have increased intracellular sodium, which leads to increased intracellular calcium, which increases the contractility of the cardiac myocytes. But digoxin isn't really used as a first-line treatment for heart failure anymore because of some of the side effects we discussed in the previous slide, as well as what we'll discuss in the upcoming slides. So that's not to say it isn't still effective for heart failure, but there are better drugs out there. Digoxin is renally cleared, so we need to be careful in patients who have renal disease, and it's quite protein bound, which is something we need to think about. So for example, if a patient is taking quinidine, that will displace digoxin from the tissue binding sites and increase digoxin levels. Also, patients who are taking sympathomimetics while they're on digoxin may precipitate some dysrhythmias. Now, the big issue with digoxin is its toxicity. And if you remember way back to our first lecture, we talked about the therapeutic index. Well, here's a good example of it. So the therapeutic range of digoxin is very narrow. A serum concentration of about 0.5 to 2.5 is your therapeutic range, and above 3 is your toxic range. So at just 35% of the fatal dose, that's where you want to be to have your effective normal therapeutic dose. Now, lots of things can precipitate digoxin toxicity. For example, if a patient's taking diuretics or becomes alkalotic and loses potassium, so that can cause them to have an increased digoxin level. And anything that makes digoxin get unbound from its protein binding sites, so you have more free digoxin. The symptoms of digoxin toxicity include nausea and vomiting, vision changes with yellow and green halos, and some dysrhythmias. Many people think that Van Gogh's yellow period was caused by digoxin toxicity. And the way digoxin treatment is treated if it becomes toxic is try to find the inciting cause, whatever it might be, treat the dysrhythmias. Patients may even need pacing if they have complete heart block, and they even make antibody fragments that are available to bind up those digitalis antibodies. Nowadays, if we see patients on digoxin, usually they're on it for rate control of some dysrhythmia. If they have some heart failure, they get an added bonus of improving their heart failure. And in our world, we may be asked to dig load a patient who's in an uncontrolled rapid atrial fibrillation. But that's usually seen in the cardiac room or in the ICU. Now we're going to talk about some other antiarrhythmic drugs. They come in different classes, and you can have a whole lecture or a whole semester on just these drugs. We're going to gloss over most of the details and just get to the most clinically relevant parts. So the class 1 drugs, Lidocaine is the best example because it's a sodium channel blocker, and as are all of these other drugs listed here. These drugs basically will decrease the rate of myocardial depolarization, and they slow down the conduction velocity, so they are drugs that slow down the heart, the conduction through the heart, that is. Lidocaine is the most common example, and we use that a lot in patients who have ventricular tachycardia or PVCs, and it's very effective. The dose is anywhere between 1 and up to 2 milligrams per kilogram IV, and you can even run an infusion at 1 to 4 milligrams per minute. As we all remember, lidocaine is metabolized in the liver, And at high enough doses, people can develop toxicity, especially CNS toxicity, so apnea, depression, even seizures, and this is all worse when patients are hypoxic or acidotic. The class 2 drugs are beta blockers, and we've talked about beta blockers extensively, so I don't think we need to focus on those anymore today. The class 3 drugs, most common example is amiodarone. Amiodarone is a potassium channel blocker. All the class 3 drugs are, and they prolong cardiac depolarization as well. They prolong the duration of the action potential, and so the heart is in the cardiac cycle, there's less time during that cycle where the myocardium is excitable. So another drug, most of these antiarrhythmics slow down the heart or slow down the electrical response of the heart. Now, amiodarone itself actually has a lot of different properties. It has some class 1 properties, it has some class 2 properties, it has some class 4 properties. It's a pretty versatile drug, and it works in all the different kinds of cardiac tissues. And as a result, it's effective in treating almost every kind of arrhythmia. It helps with supraventricular tachycardias. It helps with ventricular things like PVCs and VTach. It's even used in defibrillation-resistant ventricular fibrillation. It can be used not just for rate control, but actually for conversion of atrial fibrillation. So amiodarone has a lot of different clinical utility. The dose for amiodarone, I thought I would put it in here, is it depends on what you're treating. So if you're treating some sort of a non-life-threatening arrhythmia, say a patient's in AFib with a heart rate of 140, so that needs to be treated, but it's not like an emergency. So the goal is to get in 1,000 milligrams over 24 hours. Usually you give a 150 milligram loading dose over 10 minutes, then you work in the rest of it over 6 and then 18 hours. Amiodarone is also in the ACLS guidelines. It's a 300 milligram IV bolus in patients who have pulseless VFib or VTach. It's a very interesting drug. It has a half-time of almost a month with a very large volume of distribution and very extensive protein binding. And an interesting side effect profile. It can cause lung damage in the form of pneumonitis. It can cause hypotension. It can also cause photosensitivity or a rash, and it may affect your thyroid function because the iota in amiodarone is for the iodine. It has very high iodine content. So amiodarone is a good drug for you to be aware of and familiar with a lot of its different uses. We're going to stop here and pick up again with the next lecture. Please let me know if you have any questions about the material.